Very good morning, all of you. And just want to thank the officials of Cubicon for this privilege and the invite that was given, and more importantly, the interest shown in quality and safety. It's always a joy for us when clinicians show interest in quality and safety, because it's been a long journey to bring in quality and safety into the forefront in healthcare. And clinicians always being in the forefront, it helps a lot for taking the journey forward well when doctors are involved. So I begin saying thank you for the interest that was shown. Of course, Dr. Devin mentioned a lot of important points just before, which will be discussed. But today, we start with a discussion or a talk on patient safety. So this is a word that's very commonly heard: quality, safety, accreditation. Some people think they're all synonymous, but actually they are not. We all know that accreditation is just a milestone in that journey that we call quality or safety, and that journey is always a continuous one. So there are some basic principles that we follow, and one of those today that I'm going to talk about is the International Patient Safety Goals. As you know, whenever we talk about safety in patient care, there are a lot of things we talk about. But I feel something that I call the 10 Commandments, of course there are just 6 of them here, the International Patient Safety Goals, also forms the first chapter of the JCI accreditation standards. This is for the reason, the main reason being because you start with safety and you can end with safety. So more important, than any other standard is this implementation of International Patient Safety Goals. When we do a risk analysis across the hospital, there are a lot of issues that we encounter. There are a lot of implementations that are necessary. But this is, these 6 goals that we are going to talk about now is the mainstay in patient care. And these are all good practices that have been prescribed based on the errors that our peers or the people in the past have encountered, and the learnings that have been achieved through incidents, through litigations, through major errors that have happened in the past is what has led the international community to arrive at these international patient safety goals. Moving forward. So just to give you the right perspective as we dive deep into this topic, we all know that medical errors constitutes a large part of issues or deaths that happen. It can be mortality, it can be morbidity. WHO estimates that 1 in 10 patients in developed countries are harmed while receiving care. The AHRQ report, it rates harm to patients as 25.1 per 100 admissions in the US. From IHI, we have data which says every year medical errors are the 3rd leading cause of death in US after cancer and heart disease. We know the probabilities that in a plane crash for somebody to die or in a car accident is much lesser than due to a medical error. Now, keeping these things in mind, we also know that the public, the way they respond to errors or even discrepancies in care and cure can result in huge devastating effects, some of which goes beyond just litigation. It can also be physical harm to doctors and nurses, as we have seen in the recent past. The practice of medicine was simple, but today it is highly complex. And even small nursing homes, small hospitals, it becomes difficult, and it's a very complex process, healthcare. And when it comes to larger organizations or larger hospitals, it becomes even more complex. Now let's go see a few case scenarios. Anybody? Who is she? And why is she on the slide? Is there anything connected with her that we're talking about, except that, of course, she's a beautiful face? Absolutely. Yes, please go ahead. Exactly. So she is well known because of this fact that her mother had to undergo brain surgery, and she was operated on the wrong side of what was intended to. And this is what we are talking about, errors. Lab investigations of fasting and postprandial blood sugar showed higher readings. As a result, many patients were put on anti-diabetic drugs. These are things that do happen. Two ladies, both named Nirmala, were taken for the surgery in the operation theatre, one for DNC and the other for a cervical ligation to prevent mid-trimester abortion, and the procedures got reversed. Can happen, right? Same name. 15 hospitalized due to wrong drug given just before sterilization. So the challenge here is there's a very fine line between medical negligence and error because of ignorance. So you may not have the intent to do harm, but you may have done harm because of not following the right practices or thinking that you're doing the right thing, being convinced that you're doing the right thing and doing it, but ending up in harm. Now, when it comes to litigations, I think we all know now is like it's a very common word. People are very aware, and they raise litigations for any kind of concerns or any kind of problems that they face without even waiting to hear about it or waiting to understand what went wrong. Increasing expectations of patients. This is very relevant because what you see 20 years ago is not the scenario today. Patients are aware, one, they're very clear and aware about their rights. They have a lot of people they can go to for better information. I think in Kerala, every family has one doctor or a nurse. So it's very easy to get information. It's very easy to be led into believing that this was not the right thing to do. Expenditure in healthcare has increased a lot. Whenever cost goes up, the value expected is, of course, directly proportional. So it is expected that they get the best of cure and care. Inability of an organization to sustain, lack of skilled manpower and staff attrition, lack of risk management and safety culture. All these are problems that we face day in and day out. And sustainability of an organization depends on the capacity to be able to withstand the challenges and variations over time through a process of continuous improvement. Yesterday's scenario was not what we have today, and tomorrow is definitely going to be different. We see today how digitization has changed the face of healthcare, and probably artificial intelligence and other things are also going to come to the fore. So what it means is you cannot be where you were yesterday, and you need to continuously improve. And what we talk about is continual improvement when it comes to quality and safety. Now, we all know that the patient interface in healthcare is multifaceted. There are multiple areas, people, multiple situations they go through. And that is the reason this whole chain that we see here needs to be looked into and see if there are any loopholes, any vulnerabilities that we have to resolve. The final statement is errors cannot happen. We all know that as doctors, when we take the Hippocrates Oath, one of the major components of the oath is do no harm. This is the same principle that we follow in healthcare, and this is the same thing that they look into if or when medical negligence is contested. So coming to the main topic, international patient safety goals. As you know, we have 6 international patient safety goals, and they address specific areas which, as I said in the past, have caused errors which have been devastating in terms of mortality or even morbidity, and through which they have identified areas for improvement and has been implemented. The principles have been implemented worldwide. Now, when it comes to goal number 1, which is identify patients correctly, it sounds so simple, isn't it? We all know who our patients are, so what's the big deal about it? We do realize that patients pass through different hands, patients pass through different caregivers. At multiple times, there may be multiple patients coming with the same identity in terms of name, identity in terms of name. And there are a lot of chances where a wrong medicine was given to a wrong patient or a wrong procedure was done on a patient. It is how do you avoid this is the crux of this particular international patient safety goal. Using two patient identifiers, by default, the unique hospital ID number has to be one of the patient identifiers because it is unique. And this is the only thing that's actually unique to the patient. The name of the patient may be shared by anybody else. Anna George is a very common name. There can be another Anna George somewhere there. Next to maybe I am a patient, she's also a patient, and you never know. We might be having, different diagnoses, different procedures, but if you only rely on the name and the age, they can all be very similar. However, the unique hospital ID number, which is a one-time number generated at the time of registration, is something that's truly unique to that patient in that hospital. So the hospital ID and full name, we insist on full name because, again, first names also can be very similar in most cases. And additionally, if you want to check something further, it can be the date of birth. Sometimes nowadays we use even mobile numbers, but that can be confusing because mobile number is used to register the patient into the hospital, so that also can be unique. But hospital ID and full name is something that is most commonly used. Now, just by having the hospital ID and the name, it's not enough. What's important is how do you check this? This is the reason we have an ID band on patients. In the West, we even have bar-coded bands for which they just read the barcode and everything. When you have electronic medical record system, everything comes on the system. But today, we are slowly moving into that phase. But in most hospitals, what can be simply done is to just have an UHID band, a patient ID band, given at the time of admission, registration, and everywhere the patient goes, they check whether it is the same patient in terms of hospital ID number as well as the full name. They check it with the file, they check it with the request, the instructions, and then accordingly carry it out. So there is a check everywhere. Do not use room number or location for identification. Now this is something that was commonly used in the past. Even nowadays, today also, we see that practice is quite common. This there is a chance of an error because patients can change rooms, right, or beds. So many times when it comes to even food, diet is also a drug, right? So when it comes to diet distribution, they put the room numbers. There's every chance that it can exchange. So we insist that even for diet, even for food, you can't give a diabetic patient a normal diet. Right? So it's important that even that is treated with the same seriousness. The barcoding has come in already now in many places. In the West, it's very common, the barcoding. Before administration of medicines, blood or blood products, before taking blood or any sample collection, before providing treatments and procedures, dispensing of medications to outpatients, diet distribution, feed administration, all these are moments or typical times where the identification has to be done. Policies and procedures support consistent practice in all situations and locations. So as I said, every healthcare provider who comes in contact with the patient, not just the doctor and the nurse, it can be the technicians, it can be the hospital assistants who are transferring the patients, it can be the F&B staff who are serving the diet. Everybody should go through this protocol so that it becomes a culture across the organization. Moving on to goal number 2, improve the effectiveness of communication. Now, we all know that communication plays an important role, not just in healthcare, but even in our lives. So sometimes it's just about not doing the right communication that causes most of the problems, professional or personal life. And when it comes to healthcare, we know that the patient goes through a lot of hands. There's a lot of verbal, written, and implied communication, which sometimes, if it's not done the right way, can create a lot of issues. Let's go down to 3 most common areas where errors can be caused, which have been identified, and good practices put in place. Verbal orders. Now, coming to verbal orders, a very controversial topic because doctors still love to give verbal orders. However, we need to understand that the verbal order is in your mind. The person who's receiving the order may or may not have understood it in the way you intended it to. So tomorrow, if an error is caused, we can't blame them for that, because orders always need to be written down. There can be certain circumstances, like an emergency situation, where you need to be, you don't have the time to write down the order, you will speak it out verbally, but there is always the process of repeat back and confirm. In case of a telephone order, which again might be a common practice, if you don't have a duty medical officer or a resident on call, you will still need to say out the order. The nurse needs to write down, read back, and confirm. 3 steps. Write down, read back, and confirm. The confirmation has to be done from your side when he or she writes down and reads back. Till this is complete, you cannot be sure that the order has been received in the way you intended it to. So please note this thing about verbal orders, and if a doctor is physically present at the scene, verbal orders should never be followed. It should be written down orders. Moving on to critical value or reports intimation for diagnostic tests and even point of care testing devices. It's very important that the completion of that loop or action taken is done. It is not enough that you have given a sample and you got the result. It's important what happened after that. The diagnostics give us it's a very important step in treating patients, and sometimes panic values or critical values, meaning values which have to be alerted to the doctors so that immediate action can be taken. Normally we go through these things only maybe the next day when we go for rounds. But there can be certain tests or values revealed which cannot wait for that moment. So you need to act quick, you need to act fast. That's why you need to have a policy on critical test intimation, whereby as soon as the technician in the lab or the radiologist discovers there is something wrong and needs immediate attention, it has to be intimated to the consultant or the concerned primary treating physician, and action has to be taken. The intimation alone will not do. It is also important how quickly the action has been carried out. That could just save that patient's life, right? So that's your critical value intimation. And then you have handover or handoff communication. Again, a practice which is still in the nascent stage in India, whereby we just leave the patient after our shift thinking the next doctor or the next nurse knows it all. Handoff has been very strongly practiced in the nursing community. However, in the doctors' community, there is a lot of scope for improvement. And this is where we talk about communication. It's very important from that shift to the next shift, what has happened? What needs to be done further? Are there any emergencies or any concerns that need to be addressed? This handover is very important. It's very simple, right? When you put it in layman terms. If I was going to hand my child over to the babysitter, I would have a lot of instructions I want to give because the baby is important to me. The patient is just as important. So when you hand over your patient to the next caregiver, it's time? Sure, we'll move on fast. So we need to make sure that we ensure that they are given the right communication, and communication written is always much better than verbal. We have certain handover tools like the ISBAR and the handoff, the I-pass baton kind of formats, which help us to have standardized handover tools. Regarding safety of high alert medications, we all know there are drugs which look alike and sound alike. Some examples are put up on the slide. Simple measures like storing them apart, putting a color sticker on them so that the staff are warned, using tall man lettering to identify the names clearly of drugs having similar names makes a big difference. And of course, a double check and verification. Coming to concentrated electrolytes like potassium chloride and your magnesium sulfate, dilution is the main factor, and it is important for potassium chloride especially because there are a lot of errors that have been detected in the past that the please dilute sticker is used. Now coming to safe surgery, we all know in the OT a lot of things can go right, but a lot of things can go wrong too. And the timeout using the WHO surgical safety checklist, which is familiar to all of us, is very important, and this should not be restricted only to surgeries inside the OT. It's also important to do it for any invasive procedure, even outside the OT. Surgical site marking, very important, and must be done with the patient, as in not after the patient is anesthetized, but with the patient's knowledge. Coming to hand hygiene, again, which is the mainstay of preventing healthcare associated infections. You use the 5 moments of hand hygiene to help us realize when should we practice hand hygiene, and the steps, WHO steps of hand wash and hand rub. It is also very important that it's not just the training, but provision of resources in the hospital that will help the staff to comply with good hand hygiene practices, use of proper personal protective equipment, and transmission-based precautions. Goal 6, reducing the risk of patient harm resulting from falls. Something that is very, very underestimated, but very common in the hospitals as well as homes, is patient falls. So it's very important to highlight or remove slip and trip areas. Very important to educate the patient and the bystander on please call the nurse for assistance. Very important to identify vulnerable patients who are at risk of falls and make sure that they are given sufficient ambulatory support for the same. So how do you develop a safety culture? Training is not the answer to everything. A culture develops not just by classroom training, but by ensuring everybody follows the same from top to bottom. So it starts with the MD or the chairman or the CEO, and it has to go all the way percolating through to the housekeeping staff or the security staff. So establishing trust, taking incidents seriously, and maintaining a system where you respect people, you listen to them, you work with them, and don't blame them. So this culture of blame-free, or ensuring that everybody is aware about what is happening and coming together to be deciding in consensus what is the right way forward, is the crux of a good patient safety system or a patient safety culture. Thank you so much.